to talk about alcoves. We've been using alcoves for over 4 years prior to my coming here. Last year there were questions that were asked by the fire department around the use of alcoves, and as you know, the reason we use alcoves is because of overcapacity. So we worked with the fire department last year and looked at the risk associated to alcoves, and because there's no doors that we can contain fire, it was determined that it was a fire risk. So we immediately looked at what are our alternatives, and as you know, we do not have the alternative to close our doors. So we decided to convert our patient lounges, and you've heard a lot about that. A lot of people were upset about that. That decreased our capacity of doing private interviews on the unit. Families that were grieving couldn't use them. But what we did, and we couldn't transfer our patients from the alcoves to the patient lounges immediately, because those of you who've been in the hospital understand that alcoves are right in front of our nursing station. And we have direct access. So moving him to our patient lounges, we had to do renovations. We had to put in some call bells. We had to put curtains in, and we accommodate two patients in these patient rooms. So we moved the last patient on November 4th. The inspection was done on November 1st. And as a result of that inspection, we received a summons in January. So I think that when you're looking at what are your alternatives, we felt that the alcoves were safe, but they were close to the nursing station. The nurses could observe the patient at all times. But when the fire department looked at this and said, look, there's no doors, there's a risk, we need to find alternatives. We worked with them to find alternatives. So this is really a question of overcapacity. If we were functioning at the number of patients we should have, we wouldn't have anybody in the patient rooms or in the patient lounges, but we no longer have patients in alcoves as of November 4th, 2013. So I'll entertain questions.
So where does this charge come from, this violation?
So they did so my last patient that moved from the alcove to patient lounge was done on November 4th. They did an inspection on November 1st, and that's the result of that charge. So we were 3 days late in moving the last patient out.
Andre, when we spoke, I think it was a year ago about this issue. That's how long it's been going on for. And you specifically talked about working with the fire department at that point to prevent just this kind of thing. Can you tell me what transpired between then and?
We couldn't move quickly enough, and as an organization, we didn't feel that moving patients in the patient lounge without a call bell, all right, because they have doors, was safe. So we had to make difficult choices, and we do that every day, because when you're in overcapacity, you have to make difficult choices, and you make them, and we felt that that was the safest decision for the patients.
And what's your relationship like with the fire department at the moment? Are you still working together? I mean, you've had this fire code violation, but are you still monitoring?
Absolutely, we will always work closely. I mean, they have a mandate. Their objective is always to keep people safe. We have that same mandate, but different functions. So we work together. We have a great relationship, and we'll keep working with them.
You mentioned that the alcoves have been used in the past. Is there, I guess, any history of getting any other fire code violations because of using them, or is this the first one?
No, that was the first one, yeah.
And I guess just overall, I mean, you know, this is, as we said, this has been going on for a long time. You guys have been struggling with this for a long time. I mean, how are you, this is kind of the latest thing, I guess, in a daily struggle. How are you feeling? Like, are you feeling any hope at all that this is going to be resolved, or?
Absolutely. So overcapacity is not a Thunder Bay issue, although it's worst here, and I think that is worth a little bit of explanation. So throughout the country, everybody is dealing with overcapacity issues. However, in Thunder Bay, we have less community capacity. There had been a closure of 65 beds, which impacted us, and we felt it in the last year. Also, the other issue is that if you're in urban or less rural sectors and you get into a situation where you have 20, 25 patients in the ER, you divert for a few hours. You close your front doors, all right, and you divert ambulances. We can't do that, all right? So as a result, if I can't discharge patients to appropriate care, you have a lot of people in your halls, all right? So we've been working with the LIN, St. Joe's, CCAC, and it's truly a partnership. We're not adversaries. There has been a plan that has put together and it's submitted to government, and I'm very positive that government understands our situation. I think 3 years ago, they wanted to make sure that from a flow perspective, we were doing a good job. We proved to them that, we didn't admit more people than the provincial average. We proved to them that, we discharged appropriately. We went through all the flow, and they realized that we were a very efficient hospital, and that the problem didn't lie within, it lies in building community capacity. So I think that the due diligence in really determining the root cause has been done, and people have accepted that in the community, and they've now put a plan together that I'm hopeful government will respond pretty quickly, and we will be able to move forward.
And that plan is in place and is in the hands of, and as you say, it is a partnership, and there are plans to, but, when I spoke with Dr. Carfrellicott last week, we talked about how a lot of that seems to be stemming from the backup, seems to be stemming from long-term care. Is it, it's going to be a couple more years until St. Joe's finishes its expansion. Are things moving fast enough? What do you do at the hospital?
So without speaking to the plan, there are mechanisms within that plan that will permit us that will relieve some pressure here. Interim measures before the big construction is done that will help us. So hopefully we'll get good news on that.
Can you elaborate at all?
Well, I think that's a question for my partners. I can't speak on behalf of my partners. That's a question maybe you could have for the LIN,
okay.
All right, because it is their plan that they submitted to government.
Fair enough, but you feel that things, you don't have to
I'm
wait
very
for a couple of
positive.
years for this to be
Yep, absolutely.
to settle a bit.
We had a submission to our website from an anonymous user just suggesting that you guys are looking at the LPH as an interim solution. Is there any truth to that?
So let's go back to overcapacity. I'm not asking for the solution to this problem. It does not lie with Thunder Bay Regional. It lies with partners. So if there is a suggestion that LPH, that's a question for Tracy Butler, all right? So that's the partnership area. It's not. We're not asking for anything for us. We want the money to go into the community. We want them to build capacity. Whatever the right partner is to be able to take our patients that don't belong here, we want them to have it.
So those patients are out of alcoves since November.
Mm-hmm.
Where do they go?
They're in patient lounges.
Okay.
So we had, was it 12 or 13 alcoves? We gained capacity by 1. We have 14 patient lounges. So just to give you, I think, an example. I have 386 funded beds, so I have room for 386 people. This morning, I'm out of Gridlock. I had over 50 days of straight Gridlock, all right? And I said I had 386 beds. I have 394 patients in my bed. I'm still over my capacity, although I'm not in Gridlock, all right?
And you're out of Gridlock because it's less than 10, is that correct?
That's correct.
Okay.
Yeah. So, and what we've done is we've built capacity within so we have the patient lounges that we use when we go into overcapacity. We had 10 beds that the LIN helped us create, so we put them in the back of day surgery, not the best location. We had 2 beds that we used in PCI. So we could go up to 443 patients if we had about 20 patients waiting in the ER. So that's our flex. When you can't close your front door and your back door is semi-closed, you have to find capacity within to be able to not put patients at risk. And when we go beyond that, as you know, we canceled surgeries last year. We canceled 9 this year. We do everything to protect our services, but it's a daily battle, and people are exhausted, and we need solutions.
Okay, and so you've got 6, I'm doing the math right, which might not be, 6 admitted patients in emergency, so 8 emergency patients in emergency
This
admitted
morning?
right now?
Just 10.
There's 10 right now.
Okay, 10. So, and then how many ALC patients do you have?
I have 56. Now, they could be in regular beds, right? They're not
Right.
necessarily, so there's 56 people that require other care than we provide.
Is there anything you want to say anything else you want to add that we haven't covered that you want to say to the community or to?
Well, I think that dealing in overcapacity is a daily struggle. I want to thank I always need to mention my team. I have the doctors, the nurses, and our professionals here work day in, day out under constant stress. And if it wasn't for that team, I couldn't sit here today and say we do provide safe care, but we do need solutions. Thank you.